Welcome to SLP Nerdcast, the #1 professional resource for evidence-based practice in speech-language pathology. I'm Kate Granbois.
And I'm Amy Wonka. We are both speech-language pathologists working in the field and co-founders of SLP Nerdcast.
Each episode of this podcast is a course offered for ASHA CEUs. Our podcast audio courses are here to help you level up your knowledge and earn those professional development hours that you need. This course, plus the corresponding short post-test, is equal to 1 certificate of attendance. To earn CEUs today and take the post-test after this session, follow the link provided in the show notes or head to slpnerdcast.com.
Before we get started, one quick disclaimer. Our courses are not meant to replace clinical advice. We do not endorse products, procedures, or other services mentioned by our guests unless otherwise specified.
We hope you enjoy the course.
Are you an SLP or related professional? The SLP Nerdcast Unlimited subscription gives members access to over 100 courses offered for ASHA CEUs and certificates of attendance. With SLP Nerdcast membership, you can earn unlimited CEUs all year at any time. SLP Nerdcast courses are unique, evidence-based, with a focus on information that is useful. When you join SLP Nerdcast as a member, you'll have access to the best online platform for continuing education in speech and language pathology. Join as a member today and save 10% using code NERDCASTER10. The link for membership is in the show notes.
Hello, everyone. Welcome to today's episode. We are so excited to welcome back some of our favorite guests. Welcome back, Ingrid Owens-Gonzalez, Lisa Silveraja, and Desi Pena. Welcome back.
Thank you. We're so happy to be back.
We're so happy to see you here. Ingrid, Lisa, and Desi, you are here to discuss issues related to culture, bilingualism, and speech-language pathology. But before we get started, please tell us and our listeners a little bit about yourselves.
Oh my goodness, I didn't know we were doing that again. Okay. I am a bilingual SLP, French and English, based in Montreal. Let's see, I have a private practice called Montreal Speech Therapy, and I just love mentorship and supporting just a multicultural way of thinking and working and learning.
I'll jump in. So I'm Desi, and actually, now that you mentioned your own private practice, I realized I never mentioned my own last time. So I'm, again, like I said, I'm Desi, Spanish, English, bilingual SLP. I also own a private practice here in Maine called Panorama Speech Therapy, LLC. I'm still mostly contracting with schools and agencies in the state of Maine. And I guess another fun fact about me is that I've lived all over the East Coast, but most recently landed in Maine. So I'll hand it over to Ingrid.
Hi guys, my name is Ingrid. I am a school-based SLP, Spanish bilingual. I'm based out of northern New Mexico. I'm first gen Mexican American, and I just love working with kids. I love working with multilingual, multicultural kids, and I have a lot of things going on that Kate will share with you on the disclosure section. But right now, mentorship is really at the forefront of what I'm doing online. And I just launched my Speech Place LLC this summer. So
we're so glad to have you all back with us, and we're really excited to continue a conversation that we started with you during your last episode here with us. And I wanted to take a minute before we start our conversation to read our learning objectives and our financial and non-financial disclosures. So everyone, bear with me. We will try to get through this part as quickly as possible. We've got 5 people here today, so it's a lot of disclosing, but we're going to get through it. Okay. Learning objective number 1, describe the potential harms of over-relying on external evidence for multicultural and multilingual learners. Learning objective number 2, list at least 2 strategies to prevent harm in evaluations during the diagnostic process. And learning objective number 3, describe the importance of balancing the 3-pronged evidence-based practice model when determining treatment. Disclosures. Ingrid's financial disclosures. Ingrid is the owner of My Speech Place LLC and is the employee of a public school. Ingrid also received an honorarium for participating in this course. Ingrid's non-financial disclosures. Ingrid is the co-founder of the Bold SLP Collective and the co-host of the Bold SLP podcast. Ingrid is also the co-founder and lead mentor of the Bilingual Empowerment Through Allied Mentorship Program and an ASHA STEP mentor. Ingrid is also the mother of 2 bilingual and bicultural children. Lisa's financial disclosures. Lisa owns a private practice called Montreal Speech Therapy. Lisa received an honorarium for participating in this course. Lisa's non-financial disclosures. Lisa is the co-founder of the Bold SLP Collective and the co-host of the Bold SLP podcast and is a mentor of the Bilingual Empowerment Through Allied Mentorship Program. She is the mother of a bilingual and bicultural child. Desi's financial disclosures. Desi is the owner of Panorama Speech Therapy and is faculty of the Maine, New Hampshire Leadership Education and Neurodevelopmental Disabilities Program. Desi also received an honorarium for participating in this course. Desi's non-financial disclosures. Desi is the co-founder of the Bold SLP Collective and the co-host of the Bold SLP podcast. She is a mentor of the Bilingual Empowerment Through Allied Mentorship, and she is a child of Cuban exiles and is also raising a bilingual, bicultural child. Kate Grandbois, that's me, my financial disclosures. I am the owner and founder of Grandbois Therapy and Consulting, LLC, and the co-founder of SLP Nerdcast. My non-financial disclosures, I'm a member of ASHA SIG 12 and serve on the AAC Advisory Group for Massachusetts Advocates for Children. I'm also a member of the Berkshire Association for Behavior Analysis and Therapy, the Association for Behavior Analysis International, and the corresponding Speech Pathology and Applied Behavior Analysis Special Interest Group. I am a person of monolingual experience and a person of cultural privilege as a cis white woman in the United States of America.
Amy, that's me. My financial disclosures are that I am an employee of a public school system and co-founder of SLP Nerdcast. And my non-financial disclosures are that I'm a member of ASHA. I'm part of Special Interest Group 12, and I serve on the AAC Advisory Group for Massachusetts Advocates for Children. I also come to this discussion as a person who's experienced cultural privilege, being a white cisgender woman in the United States of America. All right, we've made it through everybody's disclosures, learning objectives. Ingrid, Lisa, and Desi, why don't you start us off with the first learning objective and talk to us about the potential harms of over-relying on external evidence for multilingual and multicultural clients. And maybe before we start, just a little recap on external evidence. What is that?
You want me to jump in or Desi?
You go first, Ingrid. You're up.
Okay. So objective 1, potential harms. I mean, they're really truly immeasurable because you're impacting people's lives. So it's not something to look over. It really like sit in that word, causing harm. But external evidence is pretty much everything that is standardized or data driven outside of who you're looking at. So all the things that have been done outside of the person that you're treating. More formally, it would be like standardized assessment, criterion, checklist, things like that, that really don't have anything to do with who you have in front of you. So that's kind of what we're talking about when we say external evidence. And then as we know, we're very, very comfortable with that triangle. It irks me to see it written in black and white letters. It says that that's the best available information gathered. It's right on the ASHA website. And I know they're talking about what the best available scientific evidence that's available, but just by putting that word right there, that's the best available information, then it makes it kind of imbalanced, right? And that's kind of like our whole goal of this conversation. It is just available information. We don't have to call it the best, but it's just data. And, you know, there's other forms of data, like the ones you collect from your client and from their family and their perspectives.
And I just wanted to jump in just quickly to say that the reason that the data isn't necessarily the best for multilingual or multicultural learners is because a lot of the data is really centered or gathered from children of a white mainstream general American English background, children who are not exposed to more than one culture. And so it's the harmful piece about relying on that evidence is that you may be over or under diagnosing children with communication needs. And what was really interesting, we recently recorded an episode with Dr. V. She's a professor at Howard, and she really highlighted the point that, you know, everybody's comes from an individual place, right? We say, you know, multilingual, multicultural, it's not, there's no such thing as a monolith, right? Like each child has a certain dialect that they're exposed to, whether that's mainstream English speakers, whether that's Spanish speakers, whether that's, you know, people who may speak, you know, one of the many languages in, for example, India, right? Like everyone has a dialect within a language. So it's something that, again, the external evidence isn't really accounting for. External evidence really looks at not so much like the granular detailed pieces, but it looks at populations as a whole, which can be really harmful because then we're not individualizing our evaluation and our treatment, which is the whole point. So
well, then you're looking at, if you're not represented in that external evidence, then it doesn't apply to you.
right.
And so then you get to the point where you're like, do I need to do research on every single population? It's like, no, you need to make smarter research
Mhm.
that
Yeah.
applies to every single
Or
population.
be a better clinician, getting your clinical eye in tune with the fact that, oh, someone from the north of Mexico doesn't speak the same way as somebody from the south of Mexico. I should be accounting for the fact that there are dialectical differences. And this happens to bilingual SLPs all the
It
time
does.
too. So I think
Yeah.
it's really important to sharpen your critical tool, you know, critical eye and your critical thinking toolbox, rather than assuming that the evidence is the best thing you can lean on.
Mhm.
And in terms
Jumping
of
into-
harm, I just wanted to highlight that I know that we're coming from a pediatrics centered lens here, but when I was working with adults, whenever you're using external evidence to make decisions about dysphagia and not making decisions based on the patient that's in front of you, you can cause a lot of harm, not just physically, but also culturally to that family, putting a lot of undue burden for not considering their cultural practices. You can cause a lot of harm if you're serving a family who has a family member who's had a TBI, and if you don't consider their cultural practices and you make recommendations based on external evidence instead of what this family really needs or what this patient really values. So it goes across our scope, even though all three of us are more school-based pediatric, but like relying on external evidence, like Desi said, can lead to over identification in the schools or under identification. And it's the same in outpatient, it's the same in acute care, it's the same in a SNF. So
I just think of who had access to education back in the day, who was all of this written for, who were the norms standardized on. What was once best practice, what was once standard is no longer the standard. And if we could reflect on that and see that the standards themselves, the external evidence is no longer good, what do we do? And how do we create these new ways of thinking? I was thinking how I was a little bit caught off guard at the beginning when I was asked to introduce myself, thinking, oh, this is a part 2. I don't need to introduce myself. And I did. And my introduction was so different from the last time I introduced myself, just 1 week ago. And I am the same person. And within a week, I've evolved into something new and something different. And to compare me to like a little white kid is so different. So how can that be the standard? I think of setting kids up for failure. This is what it feels like. You are setting them up for failure, testing them on things that they are not familiar with, that are not part of their culture, not part of their background. If you set them up for failure, then they will fail. And that is the harmful effect of it. They're failing at something because we set them up to fail.
I want to piggyback on something that you said. So if you're listening to this episode and you haven't yet gone back and listened to the first episode that we published with you all, in that previous episode, we talked a lot about cultural competency. We talked a lot about how you can do harm by not doing the work of cultural competency first when working with children who are not monolingual, who are bilingual, who are multicultural. So if you're listening, I just encourage you, today's episode, we are going to be diving into the clinical application. So please go back and listen to that if you haven't. The second piece is, I as you were talking, as all of you were talking, I was reflecting on our jobs, which is, I know, a very general perspective, but we are trained as, I'm putting this in air quotes, experts, right? We are we are trained in communication, diagnosis, and intervention. That is what we go to graduate school for. I don't believe in the term expert, so air quotes, but you get my flavor, right? And if we don't, what I'm hearing about this potential harm, I think it goes without saying that many of us, most of us, are taught in graduate school to rely on external evidence. We are taught when we go through the evaluation process and we practice I'm imagining myself as a grad student. I've got my easel, I've got my booklet, I'm doing an evaluation for the first time, and I am taught that assessment is a norm reference test. I am pretty confident that that is a standard experience. And yet there are so many people not at all represented in that test. That is, in fact, not my understanding, is that there's not an accurate measurement. Maybe has its place, but what I appreciate so much about your perspective is not only is it not an accurate measurement, but it is harmful to rely on that as a measurement. Desi, I think, or Ingrid, I think you were the one who just mentioned the potential harm, not just of the overdiagnosing and underdiagnosing, but the cultural harm, the emotional harm. And that's what made me think of going back and really looking at this through the cultural competency piece, because the potential for harm is multifold.
I wanted to add on to that when in reading about approaching evidence-based practice from a legit three-pronged approach, and I know this is jumping into a different objective, so I'm going to say it very quickly. There is a standardization approach, and that's a term from this one article in social work that is linked in the show notes, I think. And just seeing standardization approach, and this ties back to what I was thinking about. Seeing that written out, it kind of made me feel seen too, in a way. I think about this recent mentorship meeting. We were meeting for the BEAM SLP program. We met with students who are trying to enter the field of speech pathology, and they all had concerns about the GRE. The GRE was not designed for any one of us. I was labeled as an English language learner when I entered school. Funny enough, I kind of question that now, if I should have even been labeled and received those services. And I think that because of the fact that I'm bilingual, I'm not accurately represented. Those scores don't represent my actual abilities. And so I remember feeling that anxiety of, I know I'm not gonna look good on paper or on these standardized test scores. And it's because I'm not the standard. And I know that when those students brought those questions up to us, we all felt the same way. We all felt seen, because these tests don't accurately capture our abilities. And so it's really nerve-wracking when it's part of an admissions process. And I think that it's great that more universities are moving away from those standardized tests, because they just don't really give you a sense at all of who that person is. When I taught, I did a master's degree in Spanish before I became a speech pathologist. I had a student who they had to show proof of placement, right? That they could be placed in this certain level of a Spanish course. And I had a student who showed me a copy of her SAT 2 scores, I think it was. And so it gave me the whole report, what she got on her SATs. I mean, I'm not sure that person broke 1,000, on the SATs, which back in the day, I don't know what, what the numbers are now, but it was not a great score, in terms of like getting admitted to a university. And it's something that really I held on to. She was my best student that semester. I mean, she just got like a 98 in the course or something, and she was super dedicated, and it meant nothing to, to see those numbers. And it just made me so angry because of course she was a student of color. And she, again, like put her on paper, she doesn't look that great. You put her in front of me, she's a wonderful student. It just, I'm glad that she made it to that level of achievement and that wasn't a barrier. Like, thankfully her university saw something in her. But it makes me angry at the same time. So I think it's hard to remove that piece here, right? Like, it's not all, it's harm in the sense of emotional harm, cultural harm, but then we're also talking about harming people who may, who are successful or who can be successful. And it really kills me to bring this up, but I think it's also something that is a necessary part of this conversation. It goes beyond whatever pathology, right, air quotes, or disability. Like, this affects people from all backgrounds who may or may not have a disability.
Yeah. And to wrap up learning objective 1, I wanted to walk you through a scenario that I see in the schools a lot whenever a bilingual SLP or any really bilingual professional is not involved. You see a student come in kindergarten who is coming from a bilingual home. They get screened right away. Maybe they fail the kindergarten English screener, and so they get referred to the bilingual department or to the RTI department, whatever you call your RTI team at your school in your district. And then they get further into their career, kindergarten, first grade, and they're struggling to communicate, they're struggling to read. And then you either can go one direction with it and say, oh, let's just wait because he's bilingual. Or you can go the other direction with it and say, oh, we got to put him, got to test him, They got to be in special education. And so if you're over relying on these tests, how do you know which way is the right way? If you don't have the other two pieces of that triangle, if all you have is, oh, he didn't pass the kindergarten screener, and oh, he's not doing well on insert whatever standardized tests your school uses to measure reading. We used to use Dibbles, and now we use something station, insert whatever test. How do you know what recommendation to make if all you have are numbers? And so that's kind of what I wanted to posit to you guys in terms of harm. If the student truly has a communication disorder, you have now waited 2 years to support them. And if the student doesn't have a communication disorder and instead is emergent bilingual, you have now waited 2 years to support them in another capacity, right? Because we have systems in place to support English language learners, but you're just waiting for what? For him to fail another test? When all that other piece of the triangle was there to begin with. You could have talked to the parent, looked at their language history, looked at their background. Have they been to daycare? Have they been to preschool? Are they the youngest sibling? Are they the oldest sibling? Is there a history of communication disorders in the family? Is their parent concerned? And you just sitting there waiting to find out. So that's kind of where I'm coming from in terms of that learning objective. And I hope that kind of wraps it up pretty well. And then we can go to learning objective number 2.
No, it does. And I just, for the sake of our listeners who we've been referencing this triangle, we've called it a 3-pronged approach. I was not aware that this was that our evidence-based practice model was 3-pronged until maybe it might have gotten shown to me in graduate school, but it wasn't the way I practiced. And so for anyone listening, if this is a novel concept to you, you are not alone. I didn't learn about it in terms of embracing it as part of my practice until I had probably been practicing for a handful of years. And for the sake of leveling the playing field and making sure everybody who's listening knows what we're talking about, our evidence-based practice model in speech pathology is three-pronged. It is a triangle. I bet you could have guessed that, given that's what we've been calling it so far. And that triangle is made up of evidence, which is both internal and external evidence, cultural client perspectives and values, and clinical judgment. So again, often in speech pathology, we tend to think of, quote, evidence as hard numbers, research, this component of external evidence, but that is 1/3, maybe even less than 1/3, because evidence is
Less
broken
than
up to
1/3.
internal and external, right? So we really need to make sure that we are moving through evidence-based practice as a process with equal reliance on at least 3 of those components, and they influence one another. For anybody who wants to learn more about that, we actually have an episode with Dr. Mary Beth Schmidt, who wrote the EBP briefs about this process. So if you want to learn more about the evidence-based practice process in speech pathology, I will link that episode in the show notes. Anyway, carry on.
I love that
That's
you
my
said that,
soapbox.
like you weren't trained in EBP, and yet, you weren't practicing at the beginning. I feel like none of us, well, maybe Desi, but I went to grad school 11 years ago. I definitely was not trained on EBP.
I was
And
going
I
to
think
say,
we don't talk about that enough. Like you
I
come out and you're
know.
still learning.
I think that the problem is I went into my assessments in grad school the same way. Carry in your kit, bring your protocol, come on down, like I never felt like I had I think a few nuanced evaluations. Like they were very excited because they had a bilingual client for me to evaluate as my first client. And it was a scramble. I mean, I don't mean to put down anyone from my program. They did the best they could. But I felt like my evaluations were test after test after test. And I know that we read the manuals, we look at what evidence is in them that they'll work, reliability, validity, sensitivity, specificity, but a lot of our instruments are not that great or robust, even with the populations that form the standard sample. So, it's really disappointing to over rely on them so much. And I feel like, you're very kind, Ingrid. I'm not saying that I got bad training, but I think that one of the things that happens when you're a bilingual speech pathologist is you quickly pivot away from that training you might have, or you might start questioning things. Why is it this way? Why are we using this as the baseline when our clients aren't in here, right? They're not represented here heavily. It's not super well designed. Or, part of my diagnostic class was looking at sensitivity and specificity and reporting it out. We all had to take a test and spell it out. And it was shocking after weeks of talking about what is sensitivity, what is specificity, what is content validity. I feel like when we started looking at all of those different elements, we quickly realized, wait a minute, those aren't all spelled out in these manuals. We were just like, oh, So I wish I wish my professors had been like, hey, they're not great. And I wish that had been a conversation from the beginning, but it felt like the unspoken piece of grad school.
That's it right there, the unspoken piece. So no one ever said rely the most on the evidence, but that's what we saw. So when I think of the triangle and thinking back to grad school, to me, I was like, okay, again, we talked about me thinking in pictures. So I was like, okay, what does client values mean? What does clinical judgment mean? What does evidence-based mean? Okay, to me, client values, they filled out the intake. So I've got their values right there on this piece of paper. So check, I did that part of the triangle, which is of course ridiculous now that I think about it, because it's so much deeper and a vested relationship is necessary and all these things. Anyway, so I checked off intake, got the client value. Then I was like, clinical judgment. I don't have any. I better go really hard on the external evidence.
I love it. I don't have any.
I don't have- I
Everyone
don't
feels
have
that
any.
way sometimes. That's why
Oh.
I'm laughing.
No, but
Yes.
they make you feel like you don't have any either sometimes. Like,
Right.
again, I'm not trying to crap on
Like you
Bradford
didn't
today,
just
but
finish a whole bachelor's degree on something else and pass the GREs and no. you
But
have-
here's the crazy part. So I would, like, you have my whole kit, read the manual, like I'm so stressed about, did I turn the page at the right time? And am I reducing the validity because
Oh yeah.
scared the child down? Did I look at the answer? And that's why they pointed. So the stress was high.
It's so stressful.
And then this is a grad school experience, not today. Now I'm just like, yeah, flip it. It's all good. So then once I get all my data, my excellent data from this child that it definitely was not normed on, then I put in receptive skills, this based on the score, expressive skills, this. Oh, there's my clinical judgment, severe diagnosis, and check. So I've got my 3-pronged triangle, not realizing it's basically like an isosceles, just like super heavy on these couple tests.
look at you bringing out the geometry. I can't.
Yeah, I'm not gonna lie. I looked it up while you were
And
talking. It's not the right
cosine.
triangle.
What's the tangent, Lisa?
Oh
I'm so
no,
sorry.
guys!
Wow, this is the first time geometry has
I was
made an
gonna say
appearance
it.
on this show.
And weren't we
Not do well
mapping on the
GRE.
last
I am
episode?
sweating bullets the second you say isosceles.
So I brought up the isosceles triangle because the point to me was that it was so heavily based on external evidence, and the other two were just little ticks, little check boxes. They weren't actually equally being weighed. And when we talk about bicultural, bilingual kids, we actually have to weigh much more of it on the client values and our clinical judgment because the external evidence doesn't match. So that's why I brought up the new triangle. You're welcome.
Love it. And I just want to add that through that, like even within evidence, we tend to value external evidence over internal. And I kind of feel like we group internal evidence with client values, cultural values, further, diminishing the importance there. Like, oh, what we see about their culture or their language is more important than what they're sharing with us. No. So yeah, it's a mess of a geometry. It's not a triangle. It should be, but it's not.
I was going to say, and if we're trying to get to the second objective about naming solutions, I wanted to share one of the things that I use the most is resources from the Leaders Project, which is through Columbia University. It's run by Dr. Kate Crowley. So website, it has free CEUs or continuing education on performing reliable and balanced as possible bilingual or multilingual evaluations. And one of the tools that's on there is one of these interview forms. So again, I wouldn't necessarily call it like, you download this interview questionnaire and you're done. I would say that it's good to consult with. And one of my favorite questions on that form that is available through the Leaders Project is to ask parents to compare that child to other children within their community, even amongst their own kids. And I recently mentioned this to a special educator, that I always ask to compare to other children. And she's like, oh, but we're always told never to compare. I'm like, no, like it's so important because, if the parents have concerns, they're going to tell you immediately, this is not like my other children. And that to me is a big red flag in terms of trying to balance this evidence-based triangle, evidence-based decision-making in an assessment. If a parent tells me, no, they're so different from my other children, I want to know why. That's my starting point in an evaluation. So I think it's really important to list this solution because I think this is a good starting point for anyone who may be wondering, where do I start these evaluations? If we're not going to weigh heavily, if we're not going to lean it toward an isosceles triangle, how do I pivot it back toward the middle? That might be a good starting point.
I just want to jump on your word comparison because I feel that we hide a lot of what we truly do with scientific jargon. So we tell teachers and parents, don't compare. But when we put in a standardized score. What are we doing? We are comparing.
That's
to the
exactly
norm.
what I was just
What a
thinking.
norm reference
You're
assessment is.
absolutely correct. It is like the whole point is comparison, except, and I know we're going sort of back to this harm, but you're comparing it. It's apples and oranges. You cannot compare with a norm reference. It's not an appropriate comparison. I love the concept of the Leaders Project, and we'll link that in the show notes for anybody who's listening. Tell us more about what strategies we can use to not rely so heavily on the external components of external evidence.
From the Leaders Project, I also use the non-word repetition tasks a lot. They have a lot of them free for you to look on there. They have them in English, in Spanish, in Mandarin, and there's several different versions of them depending on what your age group is. So look into those, the non-word repetition tasks on the Leaders Project. That really kind of gives you another piece of the picture. It's not a whole picture, but it gives you another piece to add to your data, to your portfolio on that child if you're questioning some things. I always tend to use it towards the end if I'm still not sure with my other measures. But to get to the meat of what we're here, my strategy is using dynamic assessment. And I always like to joke, and people are like, what is that? I'm like, it's not static. And they just look at me like, okay, I need to know more. But if I never learned about dynamic assessment in grad school, so I wanted to point that out because I hear a lot of SLPs kind of feel not shame, but like a little bit embarrassed, or I don't know if there's a better word, because it's professional, but they feel a little bit less than if they've never heard it before. And I wanted y'all to know, like, I just started using that term 4 years ago. And I don't even know if I even used it in the right context. I heard it from Dr. Edith Strand on her childhood apraxia of speech course and free videos. She talks about dynamic motor speech evaluation. And I was like, oh, that's what I'm doing. But I come from a psychology background, and I learned about mediated learning in my undergrad and a little bit in grad school. So that's kind of my perspective of where I started. And of course, it came from an area of I needed to do something because all these tests were not working for my population, but that's where I come from. So if you are feeling a certain way because you've never heard of these things before, like, forget about that. Let's just, like, we know about it now and we'll move forward, because that's kind of how it happens for all of us. But it really is just looking at a skill, figuring out where the student is at, and then doing a little bit of teaching or support, and then figuring out where the student is at after. So whether you look at it from a lens of mediated learning, like Vygotsky's zone of proximal development, or whether you look at it from a lens of dynamic assessment and levels of prompting, it's all just, hey, what can this child actually do when I help them or when I remove an obstacle? And for me, in bicultural bilingual children, a lot of the times is, what can this child do if I just explain this in their home language? Or what can this child do if I take this really niche vocabulary word like s'mores, that maybe not culturally appropriate to their life? What if I substitute s'mores for something that's culturally appropriate for them and see if they can make me that sentence? So that's what dynamic assessment looks like. And that's been my biggest tool for becoming more culturally competent in my evaluations. But I feel like a lot of people look it up and they see mediated learning and test retest through all of these big words, and they're like, I don't have time for that. I would say to them, just, I think we linked it to the bilinguistics examples on what to do. You can do it so quickly just on a couple of items on the owls, say that a student had a hard time on a couple of items on the owls and you're done. And you did your clinician thing, your ones and zeros, which my favorite thing that I learned from Dr. Strand on that video, it's free on YouTube. She says, we are clinicians, not technicians. And I love that, because you need to look beyond all those ones and zeros. So I will go to those zeros and figure out, like, okay, if I let them hear it one more time, does that help? If I, say it in Spanish, does it help? If I provide pictures, does it help? And yes, I'm taking a little bit more time to do these things, but it makes my report writing that much easier. It makes my goal writing that much easier. My present levels writing, even just your justification on eligibility forms. You have more than numbers to give. And I think we had that conversation yesterday with Dr. V as well. You have an actual really good picture of the student, and parents really connect to that when they feel like you really got to know that child, when you give an example of a response they gave and they're like, oh yeah, that sounds like my child. You really dug in there. I feel like I find more buy-in anyway, because they're like, oh, you really are giving me the best picture of my kid. So that's kind of where I wanted to start off the discussion.
I have a comment and a question.
Yes.
Comment is that it sounds like you're being so thoughtful, and that the example you gave with owls was really helpful for me. And you're being so thoughtful in asking further questions about, okay, so before, when I was being a technician, maybe I'm like plus minusing, going through and saying, these are the minuses. And you're asking more questions about, why are these minuses? Are there things that I could change that would make them no longer be minuses? And so my comment with that is that any of that information you find out as a school-based person, I think is also awesome stuff to put in the accommodation section of the IEP, if your state has an accommodation section. And I guess a question I had that may not be super answerable in this modality, but if somebody is used to kind of relying on that more technician type approach and saying like, okay, here are the pluses, the minuses, I've identified the deficits. Are there helpful tips about the types of questions we might want to ask as clinicians to dig a little bit more deeply? And then also how we can think about interpreting the information that we get. So if I haven't done this before and I feel a little uncomfortable, but I know I want to start incorporating dynamic assessment more into my work, are there patterns I look for and that might make me think, okay, this is sort of tipping the scale for me in terms of I'm more likely to make this client be eligible for services versus, oh no, actually, I don't really think this person should be receiving services. I don't know if you could talk us through a little bit of that.
I can, unless Lisa, does you? Jump in.
I wanted to add before we get a little bit too far. So part of this objective that we're reviewing today, we actually covered in the first episode as well when we talked about ethnographic interviewing. So hopefully in your ethnographic interview, you've gotten some information from the parent, valuable information, unbiased information. The whole idea with dynamic assessment also is it's an unbiased approach. So you've hopefully already gotten from them a sense of whether they're concerned or not. So I would say start there. If the parent is concerned and they're saying, yeah, you know what, this kid is just not like my other kids, they're highly distractible, or I don't understand them, or yeah, whenever we go to Abuelita's house, like nobody really understands what message they're trying to share with anybody, right? Like you already have that in the background, right? So then you go into your test, and let's say the parent isn't concerned, and then you run into this question with the s'more. I love that example, right? So you run into this question with the s'more, and you're like, okay, well, really, we're talking about like in this subtest, they didn't understand this question, and there's a s'more. They didn't understand this question, and it's about going to the veterinarian. They didn't understand this question, and it's about swimming in the ocean, right? Well, maybe they don't have a pet. I mean, I know that in my family, like having pets, my family thinks pets are gross. Like Just, you know what I mean? Like it might be something worth asking yourself, like, hey, do you guys have a pet? Do you know anybody who has a pet? Do you know what a veterinarian is? Like, that's a new term for my son because we don't have a pet, right? Thinking about, okay, maybe they don't swim. Maybe culturally there is a boundary, like swimming isn't part of something that they do. Maybe they've never been to the beach, right? We're looking at what experiences they may have had and may have not had, right? So I'd say that that's really important, especially if the parent's not concerned. And I don't know, you guys can back me up on this or shoot me down. But I feel like that's when I would start saying, what's the cultural load in these questions that they missed? So looking specifically at the ones that they didn't get, what is the cultural load? What's the cultural exposure they would need to those concepts to get those questions right? So I don't know. Do you guys have an opinion on anything I've said? I also don't want
to. I support everything you're saying. I'm thinking about food. Food is a big cultural thing.
Food is big.
And in our initial interviews with the parents, I want to know what kind of food your child eats. That way, I'm not using a standardized test with cultural food from, Canada, America that this child is not exposed to. Because let's say the goal with this kiddo is intelligibility, but they're out here trying to say s'more, but you're trying to find an SM blend in a word that they've never heard. Now I'm here trying to teach vocabulary that's irrelevant to their life and then pronunciation, when I could be targeting words that are meaningful to them, that they want to be requesting at home and that parents understand. So I'm thinking about, Amy, your question about like a data-driven kind of clinician, which is what we were taught to be. And if you get a list from home of what the child eats and you find pictures, like you're even developing that relationship with the family and the child. I care about you and what your life is like. I'm not trying to pull you into mine. I'm here to support you, not fix you. So all of that in there just plays into the relationship, which builds stronger communication skills. Because how much stronger are we as communicators when we feel a connection with the person that we're talking to? So I know I'm jumping into a lot of different things here, but to go back to the original question, I would get a list from the parents of food that the child eats, and I would show them that food and have them label the food as I would on a standardized test, but now more catered to this child. And then from there, we could write up some goals.
And I was going to say, this is a nice thing too, like for a private practitioner or somebody who works outpatient, you can have them do this at home. Like this is like the intake call when you're calling them to get a sense of what's going on. These are all things that the parents can just prepare and bring and, in the 2 weeks before they come to your evaluation. And hopefully you've explained to them the value of doing it. And so therefore they bring it. It's not to say that they will, because sometimes it doesn't happen. But, I think that there's so much, again, value in giving them, letting them know that collaborative, hey, I need to know what you culturally value, bring it with you. Don't leave it out. Like, I know that that's the general feeling, right? That's separate. It's not, it's essential.
I have a quick story to share, and I may have shared it on the last episode, so you can take it out if I'm repeating myself. But during COVID, when we started Zooming in with the families and seeing kind of like the home life, it really broke that barrier of like professional in school. And it wasn't just a progress report the parent was getting or an evaluation. They were really like there for the sessions. And one big thing it was really eye-opening for me. I was doing a little standard test with a kiddo, and the parent was like, oh, they don't know that. Like, we don't eat that at home. Just putting it out there. And I can imagine myself in grad school being like, well, this is the test, please be quiet, and like trying to really meet this like experimental type of controlled. I would want it to control every variable so that I have like the most reliable data back in the day. Now I'm like, you're so right. I turned off, I like stopped sharing screen, and I was like, why don't you open your fridge and tell me what's in there? And she really pulled up her kid, and her kid started labeling different things. And then she said, oh, she never says milk because I don't know, that word is hard for her. Like, it was so much easier for me to draw these like, I want to say a treatment plan, but draw goals and objectives, very measurable ones right there in front of me, all because we just broke that whole evidence-based, I need all this external, I need to test it this way. And yeah.
And just for the sake of coming full circle and moving into our third learning objective, I just want to point out how in that story, in most of what you have all said, is really focusing on client perspectives and values, client perspective, caregivers and values, which is evidence-based practice. So again, we think so often in our professional culture, how we are, the messages we receive and how we approach an evaluation, or how we approach the story that you just told of assessing someone over Zoom, and relying on this component of external evidence, but taking the child and lifting them into using the vocabulary that is evidence-based practice, because it is patient-centered, client-centered care. Before we talk more about our final learning objective, I just wanted to go back quickly to the concept of dynamic assessment and piggyback a little bit on something you said, Ingrid, about how dynamic assessment can feel like a very intimidating term, because it's not necessarily something that we've taught. It feels very elusive, sort of like, oh, this mysterious assessment that I've never, because it's not a test booklet necessarily. It's not something that you buy. There's no directions that you follow. It doesn't live in a box, right? And in the assessment world, sometimes we feel more comfortable in a box with our directions and what have you. We've interviewed some researchers on dynamic assessment on the podcast before, so we can link some references in the show notes to talk a little bit more about what dynamic assessment is. It's a whole field of study. We're never going to cover it in the context of this episode, but I wonder if you could tell us, for our listeners who might not be as familiar, what does dynamic assessment look like for you? If someone is listening and thinking, okay, now I know I need to do dynamic assessment or rely on that as a strategy, what's next? What does that mean? Like, what does it look like?
I'll answer your question by answering Amy's, because
this is interesting.
My graduate students and that I've supervised, and clinical fellows that I've supervised, whenever I talk about dynamic assessment, they get that we have to do ethnographic interviews, that we have to balance the triangle, that we still have to do some standardized assessments because of the field that we're in, because of the setting that we're in. And then they stare at me and they're like, well, then now what? So Amy, my answer to your question, and hopefully Kate's, is start with a test that you're comfortable with. So we'll go with the OWLS example. You gave the OWLS, you did perfect, totally controlled, everything, perfectly, chef's kiss. The authors would be so proud. And then you go back and you look, they have it for you. They have the patterns for you in the back, what each 1 and 0 means. And I think a lot of people don't go back there to see, what does this 0 in question number 33 mean? Oh, it's about syntax. What does the 0 in question number 63 mean? Oh, it's about synonyms, or 45 is about opposites. And you start there. You build that pattern. If you're not comfortable with gleaning information from a family interview, gleaning information from their work samples or from their teacher observations, start there. Start with the test and then go see the patterns. And from there, you see, what tasks is this student having a hard time with? And those are the tasks that you go back to, whatever framework you prefer. I like the test. You already did it, right? Then go to the reteach and then retest, or teach, retest. So test, retest. I'm getting all confused.
Test, teach,
retest. So you already tested and you already found some patterns, and you want to go back and see if, with some support, visual support, explaining it a different way, maybe in a different modality with some manipulatives, if they can get that concept. All dynamic assessment is taking away the bias of learning, because you're not testing learning. We're not psychologists. We're testing language. So that's what I would say to my students. Go to what you already have, what you're already comfortable with, what was drilled to you in grad school, and then leave it behind and trust in your clinical experience, because it's not ephemeral. Like, clinical experience is just what it is. Like, you've learned patterns from living through different sessions, different meetings, different clients, different CEU providers, speaking to other professionals. You're just picking up information just like we pick up everything else. We all get better and better at driving somehow, and we never take a driving class again. So that's kind of how I look at it. And I hope that I answered the question, Kate and Amy.
You did.
I was
Thank
going to say the really cool thing too, I don't actually use the owls, but I use the self, unfortunately, but I use it. And I do the same thing. I just literally see which ones they got wrong. So like on the self preschool, if anyone, has access to the protocol or can think of the protocol, it has like a little box, a little grid at the bottom right hand. I just circle the ones they got wrong. And that's where I start looking for those patterns. Oh, it's always when there's a descriptor, an adjective used in the sentence. Oh, it's always when it's an ordinal concept, right? Like I start there and think, oh, okay, let me go back. And it's that teaching phase that is the most important part of a dynamic assessment. Okay, you got it wrong. Let me teach you. How many times do I have to teach you? What visual, am I using visual supports? What kind of cueing? How much cueing? How accurate are you after I remove all those cues and prompts? And I think what's also fascinating about this conversation is I think we should already be doing this. Like I think the thing that's shocking to people is the name dynamic assessment, but we should be doing this. Like I think about testing articulation. Well, I want to know how stimulable they are, right? So I'm going to go through my Goldman-Fristow for everybody, right? Like, let's just say it's somebody who is a general American English speaker, right? And there's no other culture, there's no other language. I'm going to go through and say, wow, they got all those words with final consonants wrong. Okay, I'm going to probe for final consonant deletion as a phonological process. So let me pull out these few words. Let me teach the child, hey, you know what? This word has a tail, or this word, you know what I hear at the end? I hear this sound, and see if they can do it alone or if they need more support from me. So I feel like, again, not to make anyone feel uncomfortable or like this is super basic and what are you doing? No. Like, let's undress the term, because the more we undress it, the more we understand, oh, this is just probing. Like, we're just taking a treatment target and trying it out. That's essentially what dynamic assessment is. And it's so important for multilingual students, multicultural students, because they're at an unfair disadvantage when we lean so heavily on those standardized assessments that were not based on them.
That was so well said. I love the term undressing, and just breaking it down, demystifying it so that it's not as intimidating, so that clinicians can apply this and be more effective in their assessments. In our last couple of minutes, I know we've woven conversations about the three-pronged evidence-based practice model throughout this conversation, but I just wanted to wrap up by, really taking a minute to talk about the importance of balancing those three components and what that feels like. I know in a lot of the stories that you've told, you've illustrated what balance feels like in terms of integrating client perspectives and values with maybe the external evidence that you need to take. So in some of our previous coursework on assessment, we acknowledge that in some instances, you have to conduct a norm referenced assessment because insurance will require it or your state requires it for eligibility. So I love the term balancing in this objective because it does encompass how you can move through this experience with prioritizing what you need to prioritize to do to conduct an effective comprehensive assessment. So what can you tell us about the balancing act that clinicians may need to do when moving through this experience?
I think not being afraid to, firstly, the dynamic assessment just, it makes me laugh because every case becomes a complex case when they don't fit our usual way of testing. So if you run into a complex case, which is basically everyone now, you have to dynamically assess. So that's just, I want
Lots
to
of air quotes happening here for
lots of
those
air
who
quotes. I'm
can't
so
see.
sorry.
Lots of air
I keep
quotes. So,
forgetting.
no,
Nobody can
it's
see.
fine. But
So-
but you're right. Any quote complex situation is not necessarily complex. in the
Right.
way
So
we
now
think of
that
it. So air
now
quotes.
that we're dynamically assessing, there's a lot of teaching happening within the dynamic assessment. And that's where I feel the client values and our clinical judgment comes in. And I feel that's where the balancing act is if you do appropriate assessment. So within it, if you're teaching, if you're listening to parent feedback, not being so science-y about it, I think we're really trying to turn these kids into tiny little science experiments where you got this score, therefore you fall into this category, therefore this is your diagnosis, but it isn't like that. So if you really want to balance that triangle, it all starts with like an appropriate assessment.
And I was thinking, because I know you guys, Kate and Amy, do a lot of AAC evaluations, right? Those are complex. Let's put the air quotes in there. You can't necessarily give a full standardized speaking language assessment to children who are non-speaking.
Who are also not in the norms, usually not
Correct.
captured in the normative sample.
Right. So maybe if we tie it back to that, again, in the hopes of demystifying this whole process, right? Like, it's the same exact process, right? If you're confronted with a child who is exposed to General American English and they are, monocultural, I'm trying to think of they're only exposed to one culture, right? It's the same process, right? This is out of your comfort level, potentially because of what we discussed in the first episode of this series, but let's try to think of it this way. Maybe if it's harnessed this way, it will feel a little bit less complex per se. But I think that, really going back to the idea of, okay, this tool isn't giving me the information I need. So what Lisa was saying, right? This tool isn't giving me the information I need. What is the information I need? And just asking yourself that question and then trying to balance it out. Okay, I've not had this situation before, but I am a clinician. I've not had this situation before. But I have this parent. How can I level these two things? How can I operationalize these two things so that I can move toward a better decision-making process? Because that's what, again, we talked about this very briefly, but evidence-based practice is a process. So even if you have to sketch this out, you know what I mean? I feel like, again, if you can find or advocate for yourself as a clinician for more time for these evaluations, I think that's another piece too, as another solution or strategy, say, hey, this isn't straightforward. I need to do my ethical best by this child. If you expect me to take on a complex evaluation, for example, for a non-speaking child and use X amount of time, this should be dedicated, and we should really be spending a lot more time in making sure that we get this right for this family, for this culture, for this community. So that's something else to consider adding to your toolkit. It's really the idea of, how do I peel back the layers of my cultural discomfort and enter this space to do right by this child and this family?
I just want to say I 1000% agree. That's all. Thank you.
Just listening, just listening to the kid, not through your lens, but through theirs, going back to the interview process we talked about last time. On the self, there is a question with a banana and an apple and a glass of milk. And the child is meant to say apple and banana because that's the fruit. And my kiddo said, banana milk. And I said, why did you say that? And he said, every morning I have a glass of milk with a banana. That is correct to me. That is clinical judgment. That is a clear explanation to how those two went together. And if you're stuck in, but the norm and the standard says that only fruit should be placed together, that to me is a dynamic assessment, even though you're using a standardized tool.
That's such a great story and such a great point. And I know as clinicians, when we are experiencing are going to write these up, right? And going to explain the findings of our assessment. And maybe we're in a situation where we had to use that assessment and we had to score it. But then just being able to explain that those scores don't represent the child's actual functional skill, because that is not the point of a norm referenced assessment. Norm referenced assessments don't measure idiosyncratic skill changes. They don't account for personal experience or culture. That's not what they're there for. So even if you are listening and you're in a situation where in that exact story, you felt, even, reflecting back on a choice you made, you did score that as quote wrong, you can still use narrative and clinical judgment, again, balancing this triangle, to explain that score, to diminish that score, to put context around that score. And of course, if you're in a position where you don't have to use that score, don't use it because it's not accurate, valid, and reliable measurement.
Yes, that's it. I mean, yeah, why use something that you don't need? Again, I feel like we should link this episode to the episode we just did with Dr. V, because she said the same thing.
We absolutely can.
Use a checklist. Why are you using, use an observational checklist, go to that child's classroom, ask the teacher, why are we relying on, can they repeat this sentence about a nurse, right? This is one of the questions on the
My mom is a nurse at the community clinic.
Oh my word. Right. No, maybe my mom, maybe I don't know what a community clinic is.
And I think it says my mom is the nurse at the community clinic. I'm like, who talks like that?
The nurse. Wow.
Yes.
Is it really the nurse? Okay. Well,
I'll look it up.
yeah, but I think that we've come to this point where it's really crucial to set standards for ourselves, and to make sure that we are carrying out these evaluations also just so we can make good treatment decisions too. Obviously we want to rule in and rule out, but no standardized test, and unfortunately I've seen this way too much, but no standardized test should be dictating your goals. I've seen it way too often.
Here. Can we get a little applause for that comment?
Yes.
Right.
Yeah. If I see one more goal about adjectives and adverbs, I'm going to lose it.
And there are lots of references for that. That's been well documented in the literature, that writing goals and objectives based on scores of a test is inappropriate for a whole host of reasons that we obviously do not have time to get into, but we can link some of those previous episodes we've done and some other additional literature in the show notes for anybody who does want to learn more about that relationship.
Yeah. I just wanted to add to that last objective. I always go back to my question from last episode. Who are you doing this for? Who are you doing all these batteries for? It's not going to help the parents understand, the teachers understand. It's not going to help you understand. It's just going to make it easy to fill in some boxes on your report template. I know it seems daunting, but really whenever you do dynamic assessment, the reports write themselves when you have all this information. And the thing that I like to tell my students whenever they're like, oh, it's more time, I'm like, not really. You're giving yourself credit for things that you already do. You're just putting them on your report so people can see all of the things that go into you making this recommendation. And even as an 11-year-old veteran, yesterday I learned a new thing that I need to give myself credit for that I never have before from Dr. V. She talked about portfolio. What was the word she used? Portfolio review?
Assessment or review? Yeah, maybe.
Portfolio review. I'm like, I do that all the time. I don't receive a referral, and that's credit to our counselors and educational diagnosticians in my district, is not coming from me. But my referral packets always include work samples. And I always review them. And I always use them to inform what I'm doing. And I've never known how to give myself credit for that until Dr. V yesterday gave me the words for it. And so if you're looking at this, this is new, this is different, this is daunting, I really urge you and challenge you to twist that lens back and say, I already am great at this. I already did this master's degree. I already have all these years under my belt, or even months under my belt. And I already think about all of these things when I'm making these choices. and I want to give myself credit for them.
Yeah, be a clinician, not a technician.
It's a great quote. It's a really, really great quote.
Yeah, that's all Dr. Strand. It's
Yep.
on the YouTube.
And we'll link all of the references and resources. We've mentioned a lot throughout the course of this episode.
I need to give you more links.
Yes, we will get them. Don't worry. Before we say goodbye, do you all have any advice for any of our listeners who maybe would like to learn more, if this is their first time coming in contact with these concepts of evidence-based practice, balancing, the three-pronged approach, dynamic assessment, potential harm of norm reference tests? What final parting words of wisdom can you leave our audience with?
This isn't wisdom, but DM us. Send us a message on Instagram. Listen to our podcast, shameless plug. I just think that the conversation shouldn't stop here. And if you're at the point where this is an uncomfortable topic and you're still like, wait a minute, what? Please reach out. We always try to respond to DMs. And, the three of us are open to connecting. So I think, and finding a mentor, that's the other thing. I don't know. I know that Ingrid and Lisa mentioned mentorship, but it's so important, especially if you're navigating new waters. So I'll let you guys, if you have anything else to add.
I get DMs on TikTok and Montreal Speech Therapy, and I just tell a story so that everyone can hear it. So they get the question and the story so that I could support a lot of other SLPs out there. But there's a quote I saw on JRC, the SLP's Instagram, connection over data collection. So that's what I hold true here.
I think Ingrid came up with that, right?
Mm-hmm.
Stop.
He did.
I was so proud whenever she DM'd me and she said, do you mind if I print this? But mine's a little different because I did connection and then I did the greater than.
Yeah.
Back to my math nerdiness. I did connection greater than data collection. And
oh my gosh, Ingrid, look at that.
And I was like, oh.
There was a quote that Ingrid came up with.
No, because
connection is greater than.
I did
love
greater
it.
than.
Love it.
Yes. Oh, I love her. I love Jordan. My last word, as we do on our podcast, I think my last thing would be, don't confuse internal evidence with client perspectives and culture. The triangle's already heavy on the evidence, and then we're adding a whole nother wrench in the system. I think that happens a lot more than we think, like Lisa was saying. So that would be mine. And then give yourself credit. I think you're already doing a lot of these things. You just don't know how to write them down.
That's awesome. Those were great.
So good.
As you say, the last words. Those were great last words. Thank you all so much for joining us today. Having you here is always such a treat. We've learned so much from you. As I mentioned, we will link all of the resources in the show notes. We will put a link to the Bold SLP Collective and podcast. I can confirm everyone here on this panel is so friendly and so warm and so open to conversation. So if you are listening and you have additional questions or you want to reach out, please don't hesitate. This is a very welcoming and curious and wonderful group of women. Thank you again so much for being here. We're so grateful for your time, and I am 100% sure we will find a way to collaborate with you again soon. So thanks so much for being here.
Thank you. Gracias.
Merci.
Thank you so much for joining us in today's episode. As always, you can use this episode for ASHA CEUs. You can also potentially use this episode for other credits depending on the regulations of your governing body. To determine if this episode will count towards professional development in your area of study, please check in with your governing bodies, or you can go to our website, www.slpnerdcast.com. All of the references and information listed throughout the course of the episode will be listed in the show notes. And as always, if you have any questions, please email us at info@slpnerdcast.com. Thank you so much for joining us, and we hope to welcome you back here again soon.